Ever get that feeling when you're trying to understand a complex medical topic and just wish someone would cut through all the jargon and give you the bottom line?
Oh yeah, definitely. All that technical language can get pretty overwhelming.
Well, that's exactly what we're doing today, diving deep into gastric neoplasms, basically tumors that develop in the stomach.
Right. Focusing specifically on three types: lymphoma, GIST, and gastric carcinoma. We've gone through a mountain of medical information to bring you the crucial stuff, the key differences, risk factors, diagnosis, and the most important treatment aspects.
We're cutting through all the noise so you don't have to. So think of this as your cheat sheet to stomach neoplasms. We've pulled together a lot of different sources, a whole bunch of them, to really get a clear picture of what makes each one unique.
Exactly. Where they come from, what might trigger them, how doctors figure out what's going on, and most importantly, what they do to treat them.
And our mission today, to arm you with a rock-solid, easy-to-grasp understanding of these diseases and to highlight, the huge progress being made in treating them. Okay, let's jump right in with gastric lymphoma. Now, this one's interesting because it's the most common type of lymphoma that actually originates in the gastrointestinal tract. And it sounds like it's on the rise, becoming even more common.
It is, and the exact reasons for this increase are still being investigated, but some research suggests that, better diagnostic techniques, being able to identify these cases more accurately, might be playing a role.
So we're just getting better at finding it.
That's one possibility. But there could be other factors involved too, like changes in risk factors. Some populations are seeing shifts in H. pylori infection rates, and there could be other immune system changes too.
Interesting. So even though it starts in the stomach, it's still a lymphoma. Does it present itself the same way as stomach cancer?
Well, you're right. The initial symptoms can overlap with gastric carcinoma sometimes,
Hmm.
things like abdominal pain, discomfort. But there are some telltale signs that might lead doctors to suspect lymphoma specifically.
What kind of signs?
Well, you might see swollen lymph nodes, ones you can actually feel in other parts of the body, or maybe a noticeable mass in the abdomen,
Hmm.
or even an enlarged spleen.
Okay, so if those red flags are there, how do doctors actually tell the difference between, lymphoma and carcinoma in the stomach? I mean, they're both in the same place.
That's where we bring in the diagnostic tools.
Mm.
Usually doctors will perform an upper endoscopy. It's like a thin tube with a camera. They guide it down into the stomach to get a visual.
So they can see the lining, huh?
Exactly. And they might also use contrast x-rays of the GI tract. But more often than not, the definitive diagnosis comes from a CT scan-guided fine needle biopsy. Basically, they take a small tissue sample and analyze it under a microscope.
And when it comes to treatment, this is where it gets really interesting because the primary treatment for gastric lymphoma is surgery.
Yes.
And that's kind of different from what we usually think of with lymphoma, right? Usually it's chemo and radiation.
Yeah, generally, if you think about lymphoma broadly, it involves the whole lymphatic system. It's much more widespread.
Right.
But when it's primarily in the stomach and it hasn't had a chance to spread extensively, surgery, just removing that affected tissue, can be super effective.
Yeah, so it's like a localized approach.
Exactly. And it can be curative in some cases, which is why it takes precedence over those more systemic treatments like chemo and radiation. Those are typically used when lymphoma is more, all over the body.
Okay, that makes sense. Let's switch gears now and talk about GIS, gastrointestinal stromal tumors.
Okay.
GIST, they seem a little less common, right?
They are. GISTs are relatively uncommon. They're categorized as mesenchymal tumors, which means they originate in those supportive tissues like muscle and connective tissue in the GI tract wall.
Yeah.
And what's fascinating is we believe they actually arise from a specific type of cell called the interstitial cell of Kuchal.
Okay, interstitial cell of Kuchal, what's their normal job in the body? What do they do?
You can think of them as the body's natural pacemakers for the digestive system. Yep, they regulate the rhythmic contractions of your stomach and intestines, the ones that keep things moving. They have characteristics of both smooth muscle and nerve cells.
So they're like a hybrid cell.
Exactly. They're kind of unique and essential for moving food through your system.
Hmm.
You could say they're the conductors of the digestive orchestra, keeping everything in sync.
And those pacemakers, they can become tumors.
And they can. And this is where things get really interesting because it involves these receptors, KIT and PDGFR tyrosine kinase receptors. Now, you can think of these receptors like on-off switches on the surface of cells, controlling when they should grow and divide.
Gotcha.
And in GISTs, these switches can get stuck in the on position because of genetic mutations. leading to uncontrolled cell growth. Specifically, around 90% of GE cases involve what we call an activation of the KIT receptor tyrosine kinase.
Okay, so it's stuck on.
Exactly. It's like a faulty switch. And these mutations often happen in specific locations, what doctors call exons, particularly exons 11, 9, 13, and 17, on the genes that control these receptors.
So these mutations are like little addresses on the genes.
You got it. And in about 5% of GIST, it's a similar problem with a related receptor, PDGFR alpha instead of KIT.
Okay, so KIT and PDGFR are the big players in GIST. How does knowing all this help doctors actually diagnose these tumors?
Well, what's really helpful is that these overactive KIT and PDGFR receptors, they also act like flags, unique flags on the surface of the tumor cells.
Like a marker.
Exactly. And we can use special lab techniques called immunochemical methods to identify them. Two key ones are the CD117 and CD34 antigens. These are present, or positive, in a really high percentage of GISTs. At the same time, other flags typically found on different tumors like actin, desmin, and S100, those are usually absent or negative in GISTs.
So it's like a fingerprint for the tumor.
You got it. It's like a unique fingerprint that helps us differentiate GISTs from other tumors that might look similar under the microscope, like, desmoid tumors, leiomyosarcomas, fornimomas.
That's incredible. So clever. So what about imaging? What's the go-to for actually seeing these GISTs inside the body?
So CT scans are common for initially finding and evaluating GISTs. But a scan called an FDG-PET, or even better, a combined PET-CT scan, is often considered essential.
Okay, so PET scans are pretty important here.
They are, because they can detect areas of high metabolic activity, which is a hallmark of tumors, and they're very good at spotting GISTs and seeing if they've spread.
And what about MRI?
MRI can also be useful, especially for tumors in tricky locations or when you need more detail about their size and extent.
Gotcha. Now, I noticed in the notes that GISTs can be resistant to chemo. Why is that?
Good question. This has to do with cancer cells, or at least some of them, developing defenses against the drugs.
Defenses.
Yeah, like in GISTs, there can be an increase in certain proteins, like P-glycoprotein produced by the MDR1 gene, and other similar, what we call MDR proteins.
Okay, I'm following.
And you can think of these proteins like little bouncers at the door on the surface of the tumor cells. They actively pump those chemo drugs right back out before they can even get inside and do their job.
So the drugs can't get in.
Exactly. This is the efflux pump mechanism. Makes it much harder for standard chemo to work against GISTs.
Fascinating. So where in the digestive system do these GISTs usually show up?
The stomach is the most common spot. Accounts for about 50 to 60% of all GISTs. Then the small bowel, around 20 to 30%, followed by the large bowel, about 10%. The esophagus, 5%. And then a small percentage, maybe 5%, in other places within the abdomen.
And what kind of symptoms would someone experience if they had a GIST?
Well, it varies a lot. Depends on the size where it's located. But some common ones are abdominal pain, discomfort. If it's in the esophagus, they might have trouble swallowing. Gastrointestinal bleeding, so you might see blood in the stool or vomit. And if it's blocking the passage of food, you might see symptoms of a bowel obstruction.
So it depends.
Yeah. And what's interesting is if a GIST is small, it might not cause any symptoms at all. It could just be discovered accidentally during tests for something else completely.
Ah, okay. The notes also mention different types of GC cells, spindle cell and epithelioid cell. What's the difference between those two?
Those terms refer to how the cells look under a microscope. Spindle cell GCs, the cells are long and thin, like spindles.
Okay.
Epithelioid cell GCs, they're more rounded, oval-shaped.
So the shape of the cells.
Exactly. But it's worth noting that some GISTs can have a mix of both or even not fit neatly into either category.
Okay, so how do doctors figure out if a GIST is likely to be benign or malignant? That must be a big question when you're deciding on treatment.
Absolutely. Yeah. And it's not always clear-cut, but the main factors we look at are the tumor size and what we call the mitotic count, which is just how many cells are actively dividing into the microscope.
So how fast it's growing.
Exactly. And based on these criteria, doctors have come up with risk categories. Very low risk, intermediate risk, high risk. Each has specific cutoffs for size and how many dividing cells you see.
So larger tumors and lots of cell division, more likely to be bad news.
Generally speaking, yeah.
Are there any other things that might suggest a worse outcome for someone diagnosed with the GIST?
Yes, some studies have shown that being male, having a tumor larger than 5 centimeters, and if the surgeon wasn't able to remove all of the tumor during surgery, Those are all associated with a poorer prognosis.
I see.
So those are things that doctors keep an eye on.
Okay. Let's circle back to treatment then. We know standard chemo isn't very effective because of this chemoresistance we talked about. So what are the main ways GISTs are treated?
Well, if it can be surgically removed, that's the primary goal.
Get it out!
Yeah. However, even after surgery, there's a possibility of recurrence. So that's why we have other approaches. And because of the limitations with traditional chemo and radiation, the real game changer has been targeted therapies.
Targeted therapies.
Yeah, and most notably a drug called imatinib.
Imatinib. That name rings a bell. How does
Yeah.
that work exactly?
Remember how we talked about the KIT receptor being stuck in the on position?
Uh-huh.
Well, imatinib is an oral drug, a tyrosine kinase inhibitor. It specifically blocks the activity of that overactive KIT receptor. So it's like, flipping that off switch.
That's clever.
It is. And trials in the early 2000s show that imatinib was remarkably effective in controlling GS tumors.
Wow.
And there's another similar drug, sunitinib, that can be used in some cases, often if imatinib stops working. This really shows how understanding the exact genetic drivers of a cancer, in this case the KIT mutation, can lead to really effective targeted treatments.
Amazing.
It's transformed GS from a largely untreatable disease to one where we can make a real difference.
That's fantastic. Now, I noticed in the notes that GISTs were sometimes misclassified as leiomyoma or leiomyosarcoma.
Yeah. Historically, they were often grouped with other smooth muscle tumors, like leiomyomas, which are benign, and leiomyosarcomas, which are malignant. But as we learn more about their origin, from those interstitial cells and the importance of the KIT in PDGFR mutations, it became clear they were a distinct type.
Separate category.
Exactly. And unlike typical leiomyomas and leiomyosarcomas, GISTs are less likely to cause bleeding or obstruction.
Okay, and just to be clear, the stomach is still the most common place to find GISTs, and they might often be found by chance, like during an endoscopy or barium meal x-ray.
You got it. And because they often grow beneath the inner lining of the stomach, those standard biopsies, where they just take a snip from the surface, might not be enough to diagnose them if the overlying tissue looks normal.
So it could be hiding underneath.
Exactly. And in terms of treatment, smaller tumors might be removed with a minimally invasive surgery called a wedge resection, while larger ones might require a more extensive procedure like a gastrectomy, where part or all of the stomach is removed.
Okay, we've covered a lot with lymphoma and GI cysts. Let's move on to gastric carcinoma. I think that's what most people think of when they hear stomach cancer, right?
It is. It's a malignant growth that develops from the stomach lining, most commonly diagnosed between the ages of 50 and 70,
Okay.
although it can happen at any age, really. And it tends to be more aggressive in younger people, unfortunately.
I see. Now, the notes mention that Japan has had a really high rate of gastric cancer. Why is that?
Yeah, it's been quite a bit higher than other parts of the world. And what's interesting is that studies have shown a decline in gastric cancer rates among Japanese people who have immigrated to America.
Because it's not just genetic.
Right. Suggests that environmental factors, things like diet, exposure to certain infections, play a significant role.
So where you live matters.
It really does. And we also see a higher prevalence in men compared to women.
Okay.
To give you some numbers, Japan has had rates as high as 70 cases per 100,000 people per year, whereas in Europe it's around 40. In the UK it's about 15, and in the US closer to 10. But the good news is the overall incidence of gastric cancer is going down globally.
That's good to hear. What are some of the key risk factors that might make someone more likely to develop gastric carcinoma?
Well, there are a few things. Some predisposing conditions like pernicious anemia and atrophic gastritis, which can lead to lower stomach acid production.
Okay.
Having had a previous gastric resection also increases the risk, as does having a chronic peptic ulcer. Although the risk associated with ulcers is small, probably around 1%. And then lifestyle factors like smoking and alcohol consumption. Those are also considered predisposing factors.
What about the environmental factors?
The most significant one is infection with H. pylori.
Oh, I've heard of that.
Yeah. People with a chronic H. pylori infection have a much higher risk of developing gastric cancer, something like 6 to 9 times higher than those who aren't infected. Low socioeconomic status, nationality, particularly being of Japanese descent, are also considered risk factors.
It's interesting how ethnicity can play a role.
It is. And it seems that diet might play a role not just in risk, but also in prevention, which is encouraging.
So what we eat matters.
It really does.
Are there any genetic links that might make someone more prone to it?
Yeah, there are some. Blood type A has been linked to a slightly higher risk. And then there are inherited genetic conditions like HNPCC, hereditary non-polyposis colorectal cancer, which can also increase the likelihood.
So it can run in families.
In some cases, yes.
One of the things I often hear is that stomach cancer is often caught late. Why is that?
Well, unfortunately, in its early stages, gastric carcinoma doesn't always cause noticeable symptoms. So a lot of people don't realize anything's wrong until the cancer has already progressed, maybe even spread. And that's why it's often diagnosed at a more advanced stage when it's harder to treat.
So it can be silent.
Yeah, in the early stages it can be.
So what are some of the symptoms that might eventually appear?
Well, common ones include a persistent loss of appetite, and that's often followed by significant unintentional weight loss. Vague discomfort or pain in the upper abdomen, feeling full very quickly after eating, vomiting undigested food, swelling or bloating in the upper abdomen. People might also have what we call dyspepsia, which includes symptoms like epigastric pain, bloating, feeling full early, nausea, and vomiting. And then other symptoms like difficulty swallowing, general feeling of being unwell, anorexia, and signs of upper GI bleeding, like vomiting blood or passing dark, tarry stools.
Okay. And are there any physical signs that a doctor might pick up during an exam?
Yeah, in more advanced cases, a doctor might see things like anemia, noticeable weight loss, and muscle wasting. That's called cachexia. They might feel a lump or mass in the upper abdomen, an enlarged liver, see fluid buildup in the abdomen, that's ascites, and yellowing of the skin or eyes, which is jaundice.
Wow.
There are also specific signs that indicate the cancer has spread. Bloomer's shelf, which is a firm nodule felt during a rectal exam, Virchow's node, an enlarged lymph node above the collarbone, Sister Mary Joseph's nodule, a lump around the belly button, Krukenberg tumors, which are metastases to the ovaries, more common in women, and then an enlarged lymph node in the left armpit called the Irish node.
Okay, that's quite a list. The notes also mention something called the Lauren classification, which divides carcinoma into intestinal and diffuse types. What's the difference there?
The Lauren classification is based on how the cancer cells look under a microscope and how the tumor tends to grow. The intestinal type often develops in areas where the stomach lining has undergone a change called intestinal metaplasia.
Intestinal what?
Metaplasia. Basically, the stomach lining starts to resemble the lining of the intestines. And this type tends to form more defined tumors, like polyps or ulcers.
Okay.
The diffuse type, on the other hand, is characterized by cancer cells that infiltrate the stomach wall in a more scattered way without forming a distinct mass. This can lead to thickening and rigidity of the stomach wall, a condition known as lenitis plastica, sometimes called letter bottle stomach. Unfortunately, the diffuse type often has a worse prognosis than the intestinal type.
Oh, that doesn't sound good.
No, it's not. And then there's a mixed type that has features of both.
Okay, so it can be a combination.
It can. Think of the intestinal type growing more like a clustered bunch of grapes, while the diffuse type is more like individual berries scattered throughout the tissue.
That's a great analogy.
It helps to visualize it.
It does. So when doctors see these tumors during an endoscopy or surgery, what are some of the ways they might look?
Well, macroscopically, they can appear in several forms. Raised, polyp-like growths, open sores or ulcers in the lining, superficial spreading lesions that grow along the surface, or that diffuse thickening we talked about with lenitis plastica.
So there's quite a range of appearances.
There is.
I see. The notes also distinguish between early and advanced gastric cancer. What's the key difference between those?
Early gastric cancer is limited to the inner layers of the stomach wall, the mucosa and submucosa. And the good news is it's highly curable. We're talking 5-year survival rates that can be as high as 90% with proper treatment.
90%, that's amazing.
It is. Advanced gastric cancer, that's when it's grown deeper into the muscular layer or beyond, and it's generally less curable.
Okay. And how do doctors determine how far it's spread? I see mention of the TNM staging system.
Right. TNM is a standardized way to describe the extent of a cancer. The T describes the size and extent of the tumor. So T1 is a small superficial tumor. T4 means it's grown through the stomach wall and maybe even into nearby organs.
I see. So T4 is not good.
Not so good, no. The N tells us about lymph node involvement. N0 means no spread to the nodes. Higher numbers, like N2, indicate spread to more nodes or more distant ones. And M tells us if it's metastasized, spread to distant parts of the body. N0 means no distant spread. M1 means there are metastases, like in the liver or lungs.
Just a way to categorize it.
Exactly. And this TNM staging is really important for planning treatment and predicting the patient's prognosis. A higher stage, meaning higher T, N, or M, means a more advanced cancer.
Okay, that makes sense. So how does gastric cancer typically spread from the stomach?
Well, it can spread in a few ways. Direct invasion of nearby organs like the pancreas, colon, liver. Cancer cells can also travel through the bloodstream to distant sites, usually the liver first, then the lungs and bones. And then lymphatic spread is very common. Cancer cells travel through the lymphatic system to nearby lymph nodes. That's how you get Virchow's node in the neck.
I see.
And then there's transperitoneal spread, where cancer cells break through the stomach wall and spread across the lining of the abdominal cavity. This can lead to fluid buildup, ascites, and those Krukenberg tumors in the ovaries in women. The Sister Joseph nodule, that lump around the belly button, is also a sign of transperitoneal spread.
Wow. What are some complications that can arise from all this?
Complications can include fluid buildup around the lungs, pleural effusion or in the abdomen, peritoneal effusion, blockage of the stomach or small intestine, bleeding from the tumor, and jaundice if the liver is affected.
So, a lot of potential problems.
Unfortunately, yes.
When someone has symptoms that might be gastric cancer, what else could it be? What other things do doctors need to consider?
Well, it's important to rule out other conditions. Benign gastric ulcers, other types of growths in the stomach that aren't cancerous, gastritis, which is inflammation of the lining, gastric polyps, even inflammatory bowel diseases like Crohn's disease, which can sometimes affect the stomach. One historical clue that can be helpful is that pain from a cancerous ulcer isn't usually relieved by antacids, doesn't come and go predictably, and isn't relieved by eating or vomiting. That can help differentiate it from a benign ulcer.
That's a good distinction. What kind of tests are done to actually diagnose gastric carcinoma?
Well, we usually start with general tests. A full blood count to check for anemia, liver and kidney function tests, measurements of enzymes like amylase and lipase. Doctors might also check for certain tumor markers like CA72-4, CEA, and CA19-9.
But those aren't specific to gastric cancer, right?
You're right. They can be elevated in other conditions too. A stool sample might be checked for hidden blood. Imaging tests like a chest x-ray and sometimes a bone scan might be done. But the gold standard is an upper GI endoscopy with biopsy. This lets the doctor see the lining of the stomach and take tissue samples from any suspicious areas for examination under a microscope.
So endoscopy is key.
It is. Double contrast studies, where the patient brings barium and we take x-rays, are less accurate, especially for early cancers and distinguishing between benign and malignant ulcers.
Okay.
CT, MRI, and ultrasound scans are helpful for assessing how thick the stomach wall is and checking for spread to other organs. And in some cases, a laparoscopy, a minimally invasive surgery with a camera, might be used to check for spread to the lining of the abdomen.
So endoscopy seems like the most important one. The notes even describe some of the differences you might see between a benign and a malignant ulcer during an endoscopy.
Yes. A malignant ulcer often has a more irregular shape. The base might look discolored or even have signs of bleeding or dead tissue. The edges are often raised, uneven, rolled, or heaped up. The tissue surrounding the ulcer might also look abnormal. A benign ulcer, on the other hand, usually has a more regular shape, round or oval. Smooth, straight edges that are level with the surrounding lining. The base of a benign ulcer often looks clean, and the normal folds, the rugal folds, often radiate right up to the edge of the ulcer. Benign ulcers are also more commonly found on the lesser curvature of the stomach and tend to be smaller.
So there are a lot of clues.
There are. The endoscopy can tell us a lot.
So once you have a diagnosis of gastric carcinoma, what does the treatment plan usually look like?
Well, the initial steps often focus on improving the patient's overall health. This might mean addressing nutritional deficiencies, correcting fluid and electrolyte imbalances, and treating anemia.
Get them strong.
Exactly. Before we start any cancer treatment, we need careful preoperative staging to figure out how extensive the disease is and if surgery is even an option. Preoperative care can involve nutritional support, managing existing symptoms, blood transfusions, making sure the patient's hydrated, giving antibiotics to prevent infection, and a thorough review of their medications and allergies.
So getting them ready.
Exactly. And if the patient smokes, we'll strongly advise them to quit.
Of course.
Now, surgery is a major part of treatment, if it's possible. The main types are gastrectomy, which involves removing part or all of the stomach, and will also take out surrounding tissues and lymph nodes.
I see.
A subtotal gastrectomy means we remove only the lower part of the stomach. That might be enough for tumors in the antrum, the lower section. A total gastrectomy means removing the whole stomach. and that's usually necessary for tumors in the middle or upper parts of the stomach. After the stomach's removed, the surgeon has to reconstruct the digestive tract so food can pass through. This might involve connecting the esophagus directly to the small intestine, a procedure called anaesophagojejunostomy with a Roux-en-Y reconstruction, or connecting the remaining stomach to the small intestine, a procedure called a gastrojejunostomy, or Billroth II reconstruction.
So pretty complex surgery.
It can be, yes. And in cases where the cancer is too advanced to be completely removed, we might do palliative surgery. That's just to relieve symptoms like obstruction or bleeding.
Okay, I see. What about post-op care? What happens after the surgery?
After surgery, patients are usually admitted to the PCU, the post-anesthesia care unit, for monitoring. Nutritional advice is a really important part of recovery. We often start with small, frequent meals and gradually advance the diet. Some potential complications include leakage from the duodenal stump, if a subtotal gastrectomy was done, secondary bleeding, and long-term nutritional deficiencies because of the stomach removal.
So it's a long road to recovery.
It can be, yes.
What about chemo and radiotherapy? What role do they play?
Chemo regimens are definitely used in the treatment of gastric cancer. But the notes you provided suggest that a specific regimen, called the Marsden regimen, hasn't shown a benefit on overall survival. However, chemo is often used along with surgery, either before to try to shrink the tumor or after to try and prevent recurrence. And postoperative radiotherapy, meaning radiation given after surgery, may help reduce the risk of the cancer coming back in some cases.
Okay. Are there things people can do, lifestyle changes, diet, to try to reduce their risk?
Yes, there are some things. The notes you provided highlight diet as a key factor.
Makes sense.
A diet rich in vegetables and fruits seems to be protective. Adequate vitamin C and E intake is probably protective. And then there are things that might be protective, like carotenoids. Those are found in colorful fruits and veggies, whole grain cereals, green tea. And of course, not smoking and limiting alcohol are also important for overall health.
So healthy lifestyle, healthy diet.
It all adds up.
It makes a big difference. When it comes to how well someone does after a diagnosis of gastric cancer, what are the most important factors?
Early diagnosis is absolutely crucial. And for those who do undergo surgery, the depth of invasion, how far the cancer has grown into the stomach wall, and lymph node involvement are the two most important things for predicting survival.
Okay. Finally, the notes mention a big difference in 5-year survival rates between the U.S. and Japan. What are the numbers?
Yeah, it's pretty significant. The reported 5-year survival rate in the U.S. is around 10%, while in Japan it's much higher, closer to 50%.
Wow, that's a huge difference.
It is, and it probably reflects a lot of factors. Maybe more aggressive screening in Japan, leading to earlier detection, possibly differences in diet, genetic predispositions, and perhaps even variations in treatment. It's complex.
Okay, so we've covered a lot of ground here. We've looked at gastric lymphoma, GIST, and gastric carcinoma. Could we recap the key differences between these three?
Sure. So gastric lymphoma, while it can have similar symptoms to stomach cancer, is a cancer of the immune cells that starts in the stomach. It's often treated primarily with surgery.
Okay.
GSEs are uncommon tumors that originate from those special pacemaker cells in the stomach wall. They're frequently driven by specific genetic mutations in the KIT or PDGFR genes, and they're often resistant to traditional chemo, but targeted therapies like imatinib have really changed the game.
Right.
And then finally, we have gastric carcinoma, the more common stomach cancer arising from the lining. It has several risk factors, including H. pylori infection and diet. Early detection is key for a good outcome, but unfortunately, it's often diagnosed at a later stage.
It's amazing how different they are, even though they all involve the stomach. Really shows how important accurate diagnosis is and understanding how each tumor type works for effective treatment.
Absolutely. And the progress we've seen, particularly with targeted therapy for GIST, is incredibly encouraging. It offers real hope for patients.
Absolutely. So thinking about that difference in survival rates between the U.S. and Japan, it makes you wonder, what are all the things beyond just the medical treatments that are contributing to that disparity? Is it earlier detection, different diets, genetic factors, or a mix of everything?
That's a really good question.
It's definitely something to ponder. Maybe even do a little more research on your own.
I think it'd be fascinating to dig deeper into that.
Thanks for listening to The Deep Dive.